West Health convened a group of experts yesterday at Fenway Park, which is pretty awesome. I'm now a Red Sox fan. I was a Yankees fan when I came up on the Acela, but I'm a Red Sox fan now, and I love Fenway Park. But we convened a group of specialists, and we had a conversation around successful aging and the business case. And we want to share some of those insights with you now in the form of a panel. And spoiler alert, there's going to be a little bit of participation in this one as well, because we want to bring you into the conversation towards the end of this as well, and get your ideas in, and we'll capture those and make it part of the record also. So when you're listening to a panel, it's helpful to know, you may recognize a number of these folks, but let's do some quick intros just so everyone knows who's here on the panel. Maybe your name, what you do, and why you're so passionate and care deeply about successful aging. We did not rehearse this, by the way, but
no, we didn't.
But I know you're here, so I know you're passionate, so yes.
You want me to start?
Sure.
Okay. My name is Nora. I'm the Director of Policy and Programs at the Milken Institute's Center for the Future of Aging. I will just mention a few other jobs because I just started there in 2018, and it'll look like I can't keep a job, but I'm very interested in things. I just recently was with M4A, where Sandy Markwood was, working on the integration of health and social services with community-based organizations. And before that, when I had the opportunity to meet the West Health folks, was when I was Executive Director of the White House Conference on Aging in 2015. And the only other job I'll mention, because I saw a lot of my former co-workers here, I was at the Office of the National Coordinator for Health IT for 3 years. So I know just enough about health IT to make me dangerous, but you'll see that I still have opinions about it. So.
I love a little danger on a panel. This is good.
Hi, I'm Charlotte Ye. I'm Chief Medical Officer for AARP Services, Inc. And I'm really passionate about aging because one, it's the numbers. But the second most important reason is I really believe that aging is that one thing that binds all of us. If you think about, disparities by race, culture, education, gender, income, you name it. But there's one thing that's a universal truth is every single one of us is getting older every single minute of every day. So if we don't solve for it, it is about us. And we have to solve for it.
Nice. Thanks. Tim?
Great. Tim Lash with West Health. And as Shelley explained, West Health is advancing a portfolio of applied medical research, policy research, and outcomes-based philanthropy, all focused on successful aging. As the Chief Strategy Officer, I have the privilege of working with the team across that portfolio of 3 organizations. And from a passion standpoint, we know the demographics. I think what's most exciting is that this is an incredibly high need, well-deserving population that when you get it right, you can have a real impact. And getting it right doesn't require us to go to a lab and discover things. I think there's opportunity right now, and there's a crisis right now, but there's opportunity right now to really have an impact, a real human impact.
Nice.
Hi, thanks for having me. I'm Efrem Castillo. I'm the Chief Medical Officer for UnitedHealthcare, Medicare, and Retirement. So I have responsibility for the Medicare Advantage population. Just so you guys recognize, we have about 15 million seniors that we have responsibility for. I used to be a doc, still am. But I used to practice for 20 years, and very eloquent, all of you, around what makes you passionate. I remember being in a room with patients, and the aging population was such a joy. And I think they're also faced with so many areas where we have a responsibility and also an opportunity to make their lives better. So I just always remember some of the patients that couldn't afford food, but would bring me lunch.
Thank you.
I didn't get to say my passion.
Oh, yes.
I'm sorry, I forgot the question. So one of the things that makes me so passionate, and what you said just really reminded me, is my parents, which I think a lot of us think about aging in terms of our parents and how we saw them age. And my mom died when she was 52 of breast cancer. And I was only 12 at the time. So that really brought home to me that each and every day that we have and we wake up and have a new day is a great thing. So getting older is something we should celebrate and feel happy about, and happy that we have another day to live. On the opposite end of the spectrum, my dad, who was a physician as well, had Alzheimer's disease, and we had to go through all the issues that families have to deal with when someone that is the smartest person they ever knew, they look up to, can't even remember your name. And so I think seeing the aging from that perspective has really made me passionate about how we make it good for people of all ages, from when they're 54 like I am today, to 94 in what we see. And there's just so much difference between that. And the one thing I would just say with the 94, and don't just say because you're 80 or 90, or, you know, as Alice mentioned, the 80-year-old doing her weights. I don't know how many of you all have seen the Ruth Bader Ginsburg documentary, but it is so awesome. And if you haven't seen it and don't feel inspired, like I want to be Notorious RBG when I'm 85, there's just so many models for us to look to that can make us excited.
Nice. So now you know who's on the panel and why they're here and the next movie you need to see. Get that on your to-do list. Let's share some of the insights from yesterday from Fenway Park, some of the things that we talked about, some of the learnings. And Tim, maybe I'll go to you first with thinking around the market opportunity and the challenge. So how would you characterize the market opportunity for senior-specific models of care?
I guess it's huge, it's enormous, it's bigger and better than ever. So I couldn't resist. I spent a lot of time in Washington, so I thought that'd be an appropriate way to start. But on a more serious note, you know, when you think about sort of the demographics, and we don't need to go through them because we're familiar with them, there's a segment of the population that has enormous spending potential, and I think less so now, but you know, historically there's been a lot of focus on that as an opportunity and that as a driver of the longevity economy. We heard earlier today that you know, 40% of Americans can cover an unexpected expense of $400 or more. It's worse for the senior population. So while there's certainly a segment of that population that has the ability for self-pay, really, you know, opportunities and market opportunity that's motivated or focused on that, I think, you know, are, you know, likely misguided and won't really drive the majority of the opportunity here. I think rather there's growing recognition that this segment, you know, has complex needs, that has unique needs, and that not getting it right is catastrophic from a societal impact perspective and from an economic perspective. And I think as a result, we're seeing you know, an increasing demand for senior-specific models. I think also there's a recognition, and I'll talk about timing in a second, but there's a recognition that getting it right for this segment or this cohort also will allow us to deliver better, more efficient care for the broader population. And you know, again, you know, not getting that right, and we've talked about sort of the trajectory of healthcare costs in the U.S. and the ineffectiveness, you know, compared to other developed countries, is catastrophic as well. Something, you know, a battle we just can't afford to lose. So I think, you know, for those reasons, we're seeing, you know, an uptick. I think timing also matters, and you know, having spent, you know, a fair amount of time through my career in the innovation space, you know, early stage visionary investors and visionary entrepreneurs in many cases need to bet against the consensus, right? Because the consensus is built into the price of an asset, and they also have to bet ahead of sort of the general stakeholder competencies in terms of understanding, and I'll use value-based care as, you know, an example of that. You're talking with a colleague yesterday, you know, when, you know, going through pitch decks to investors, used to have to spend a lot of time on that. Now you can skip that because the market is really starting to understand that. And I think as a result, we're shifting from earlier stage, more discrete, lower levels of investment that you know, historically were sort of onesie-twosies, you know, 100 patients, one center, trying to understand something, to more value-oriented, pragmatic, and even institutional investors that are coming in at scale. And I think, you know, at scale is key, because we need, you know, this is a big population, and we need to test things that have the ability to scale and sustain themselves. And we're now starting to see successes and also fabulous failures, but at scale. And at scale, we can start to extract some lessons learned, put the puzzle together to really understand at various levels of the system what the ROI is.
Yeah. Other thoughts around characteristics, just as we frame this up?
I mean, I do think there's good news here, though, is right now nobody owns the market. There is nobody who actually has cracked that secret code or the secret sauce. So I think I'm being always optimistic. I think the opportunity is sitting before us, and the one who cracks that code, has got a great future, not only for their company, but for us too.
Nice. Either of you guys? No? How's the market different than it was 5 years ago?
Well, I can start on that. The baby boomers are the big answer. Even in yesterday's discussion and some today, people think about seniors as them, and it's really all of us. I mean, so many of us in this room. And my husband is about to turn 65 this year, and he still runs alongside me and 10Ks and things. And so our vision of what that means is so different that I think so many baby boomers who changed the way we think about so many things early, as they become older, are thinking about aging in a whole new way. And so the sheer numbers are one thing, certainly the cost associated with it, but I think because there's just so many energized people that are over 65 today that are going to reinvent how we think about aging and want investors to invest in products that will make their lives better.
So I think, to me, there's two really big changes that happen. And the first is, I know 5 years or even 7, 8 years ago, if you talked about investing in the senior population and aging, the eyes would roll and say, really? Why is that important? And over the last 5, 6 years, we're now recognizing that this is a market to actually go after. And the second thing I think that has changed is it's always been about what can we do in the healthcare system. We're talking about what we can do in the community, but we are now talking about what's the consumer role? Where is the engagement? What about behavior change? Those were things we never talked about 5 or 10 years ago because we thought if we build it, they'll come. So I think those two things have really changed and I think prompted kind of more exciting innovation to come.
Yeah,
go ahead.
To pick up on your second point in terms of the what, right? I mean, so clearly we've decentralized the focus some. I think also if you look back, there were a lot of technologies in search of a problem, right? And no one wakes up in the morning and says, "I'd like some telehealth today," right? So I think that the market has shifted a little bit in really understanding the pain points, and now we're seeing more holistic solutions and services. And I think also the investor base is catching up to that. For a product, it's relatively easy or easier from a valuation perspective to say, there's a certain number of patients, that's the segment, you penetrate that, you have some price, you have some share, and there's the opportunity. Services and the ROI around that are a little bit more complicated. But ultimately that's where that's where the answer and the solutions lie. And products will feed that and enable it, but they need to be focused on fundamentally enabling a new delivery of care versus enabling a siloed approach of we have telemedicine or we have remote monitoring or any other sort of buzzword that you want to throw at it.
Yeah.
I agree with everything you guys have said. The consumer has driven the consumer's ability to understand and provide input to a portfolio of products. We often think about a portfolio of solutions and have not necessarily understood what the consumer demands from all of us to provide those solutions. I also think that they have become more, and this isn't meant to sound derogatory, but more aware of what's available. Which, when we think about paternalism and the way that medicine had been practiced for many years, that paternalistic demand, if you will, or expectation from provider to patient. So understanding all those forces, and then, frankly, a lot of it, the money. How much are we going to spend? How much can we spend? Who can invest? Who can afford not to invest? All those factors then weigh in, and if we can figure out how to understand the community and the resources that can be provided at a level that understands the patient more wholly, I think those opportunities are now really starting to emerge.
Nice. So as we start to talk about consumers, who are some of the other stakeholders that we need to be thinking about and designing for when we talk about senior-specific models of care? And maybe even what are some of their key needs and wants?
Go ahead. Yesterday when we talked about successful models and failures, which of course we all came away from that discussion, I think, thinking there needs to be a place where you can go and learn from other people's failures, because we see a lot of the reinventing the wheel out there that's happening. And but I think the ones that are the most successful were the ones that really looked at all the stakeholders, and the stakeholders included, certainly the investors, thinking about how, sometimes you'll talk to folks who are physicians or community-based providers that say, well, it's the right thing to do and people really like it. And that's all true, but you need to also understand it from the payer's perspective, what is going to be in that. And there are folks, the sophisticated models that really knew the pain points of all of the stakeholders and what they would be. So the community is key. As well. Trust was a big issue that came up a lot, and I think that sometimes is the new gadget, the new thing that somebody's going to use. If we just build this app, everybody's going to log on and put their weight and their blood pressure down, and that's just not the way people act on a daily basis. And so I think really fundamentally understanding what the patient wants, what the patient needs, what's going to motivate them to participate in something is key, and something that we need to spend more time on, what matters to them the most.
Yeah, so just to build on that, when I think of the companies that are successful and the ones that will be successful, they really know how to integrate the wants and the needs and the pain points, what I call the 3 Ps, the person, the provider, and the payer. So I don't know about you, but I go to a lot of meetings and we go to a lot of discussions, et cetera. And I always find that typically 2 out of the 3 are there complaining about the 3rd, right? So you have doctors or providers and patients getting together and say, the real problem of why we can't do what we want to do is because those payers are getting in the way of the doctor-patient relationship, right? And then you get the providers and the payers get together and they go, the real problem here is those darn consumers. They just don't do the right thing. They're not engaged. The real problem is the consumers. And then the consumers and the payers get together and say, the real problem, nobody understands quality care. The providers don't follow best practices. And where I find the best innovation and people actually starting to achieve success is they put all 3 in the room together and they talk about what is it that's going to make your life better for you as a person, for you as the provider, how do we bring you back that joy in your practice? And then for the payers, we have to pay and be very cognizant that there's a business need, no mission, no margin, no mission. So that's how I'd put it.
Yeah, so I think a key theme that we've heard from both of you is that you need to understand, the depth of the problem, at a greater fidelity than perhaps we have in the past, and that you really need to understand that at the level of the community, the person, and the family. I guess what I'd offer on top of that is that, essential to that is the assumption that good ideas are not enough, right? And when you look at the good ideas that are coming out, and it ties to something we've talked about, as products versus services. Many of the good ideas, and what I think what will really hunt, and have an impact, require changes in workflow. And the provider is the next closest to the person and their family. And I think the opportunity there is, to really fundamentally understand the operations. What are the changes that are required, and where are we today? And if you don't pay attention to that, you're really destined to failure. In trying to really redefine the delivery. And I think that's an area that often the operational side of it often goes overlooked, and it's a huge need. For providers today, you get it right, and I think you can see some really transformational and impactful things in terms of outcomes and cost savings. But you get it wrong, and you end up with an even more bloated system than we have today.
Do you think that so I think we're all consumers of care at some level. Do you think in the three Ps that the community, I think I know what your answer is going to be, but do you think that the community has to play a much larger, and when I say community broadly, community-based resources, community-based programs, has to play a much larger role than they have in the past? And then do you think we should, and payer, help subsidize or figure out how to at least coordinate that? I guess I'm asking a question. Sorry, moderator.
Oh, hey,
No,
this is cool.
I think it's absolutely important. You know, we you know, as part of AARP services, working, you know, actually with United in the Medigap plans, you know, we actually trialed a number of different kinds of care coordination. This is in the fee-for-service market.
Right.
This is not in managed care. I mean, this is where people cherish that freedom of choice. So we did these pilots that we tried disease management, whole person case management, depression management, you know, you name, we tried the pilots. And what rose to the top was not disease management, you know, that just sort of barely broke even, but the whole person case management actually had better outcomes. We saved Medicare 5% dollars, you know, over time with a positive ROI, 2-to-1 overall, 3-to-1 by the third year of this program. Because what we learned was people are not diseases. People are people with their families, their caregivers in the community. And when we approached how they lived life in their community, all the other things followed: better outcomes, better experience of care, better satisfaction, and frankly, less money.
Can I add on that? So as I mentioned, I was at the National Association of Area Agencies on Aging most recently, and with funding from the John A. Hartford Foundation and West Health and others, we started the Aging and Disability Business Institute, really to have health plans and health entities work more closely with aging and disability community-based organizations, because we believe so much that they really know what's happening on the ground and have served these complex patients for a long time. But often these community-based organizations don't have the business acumen to contract with them or know what the payers want. So that's the whole role of that. I'll just share a story from that just shows the power of relying on these community-based resources, which again, the successful models that we talked about really already had trust. I think sometimes people go in with a new model and think we're just going to put this here and it's going to work, and people say, who are you? I don't know who you are. And you work with people in the community that are trusted or have a trusted brand. It makes a big difference. But you know, the story I'll share is right here in Massachusetts, one of the leading area agencies on aging is Elder Services in Merrimack Valley, and they work with the Medicaid program a lot, where you know, the plans would come in and say, our biggest problem is missed medical appointments. Like, these people just don't show up, and we waste so much time because we have all these appointments and they don't show up. And so Elder Services said, okay, we'll take care of it. And they went and visited, which was what they do, a lot of these clients that weren't showing up. And one example they gave was, you know, a woman who lived in a 3-story walk-up. She was wheelchair bound. And when they went up and said, you know, why don't you go to the doctor? You have all these appointments, you miss it. And she said, you know, the only way I have to get there is when my husband is off of work. He's not salaried like all of us. He doesn't have paid sick leave. If he's away from work, he doesn't get paid. And when he's home, then he has to carry her down the 3 flights of stairs and put her in the car and get her to the doctor. Well, that's kind of a barrier to access. So the social services folks who know about these resources in the community arranged for this woman to get accessible housing and to get transportation provided to get her there. Guess what? She never missed a doctor's appointment again. So it's some of those things that I think we really need to be much more creative about how we're solving some of these issues.
Exactly. That was a loaded question.
No, and a good one.
No, but I appreciate the leading question. I agree with what was said. I guess what I'd add to it is that I'm optimistic, right? You know, I think, you know, the community is central, and I'm optimistic that there's growing recognition, you know, of the central nature, right, of the focus on the community by those in influence. And I'll share a story. You know, there's a meeting every year, Health Evolutions, which is in California, and it brings sort of, you know, health executives together from across med tech, pharma, payers, some policy representation. And you know, it's leaders of those organizations, you know, talking about what they've discovered, you know, or what they've solved since last year. And if you go back, you know, 3 years ago, there was a lot of discussion around the importance of, you know, medical, right, and dental, and integrating that with, you know, those things together. And last year it was, you know, that they've recognized and figured out that we need to focus on the aging population. And this year there was a central theme around social determinants, moving beyond medical and really relying on the community and community-based organizations. it's simultaneously encouraging, but also frustrating because these are things, for people that have been working in aging, like with their core tenets, them to be true. But the market is catching up, and those that are steering large organizations are catching up, embracing that, and really leaning in with the resources that are required to have an impact.
So I totally agree with all of this, but I do think there is one really big challenge out there. And that is, if you think of community-based organizations, a lot of them are charitable or publicly funded, and so they are really going after, they're living hand to mouth, and they're going after the most vulnerable of the populations. So what they don't have is they don't have that ability to translate what they're doing into the business case. Right. It's to your point of why people should invest. They are extraordinarily good at telling us the story, the storytelling, the community. The payers, or the ones, in the healthcare industry, we're really good with the numbers. We just don't have the stories. So if we really are going to make this community be integrated, the community organizations have to understand how to translate that into the needs of the payers. What is its benefit to cost? What is its benefit to outcomes? And if you can't do that, how are you benefiting acquisition and retention? I mean, think of those drivers. And then for the payer side is to say, if you want to connect to that community, you have to put a face on those numbers. And how do you tell that story that people want to come to you and believe and trust that you are out for their interests?
So Charlotte, let me ask you a question around that. And I agree, but if you look at the business case, intrinsic to the business case is what is the return, right? And I agree that community-based organizations can they can get better. We all can get better at articulating what that return is. But the return and the calculations are only as good as the data that you put in. And if you look at the securities market, I mean, there's rainbow options and other things. I mean, we can value anything, right? But that you rely on the data that you put in. And I would suggest that even at the payer level, we talk about returns related to the total cost of care or other things, but the measures, the algebra and calculus that we're using in the data that feeds that in terms of what are those actual savings is actually still quite crude. So I agree that the community-based organizations could get better, but I think that the payers and all of the stakeholders need greater fidelity and a little bit, perhaps more sophistication in terms of how we calculate these things.
I completely agree. And I think when we evaluate, for example, supplemental benefits that CMS is going to allow, we're faced with the same issue. So how do we value that? How do we understand if we go beyond, for example, if we go beyond traditional home health and provide at-home care? How does that relate to a return that we can then quantify for all the constituents? So for the home health or the benefit for the payer and then for the member. So how does that all equate? And I completely agree. We have not, as an industry, I think, opened our eyes enough to be able to evaluate in a way that you're suggesting.
So I would just say, what we discussed yesterday, which I thought it was a great gathering, just like this one, of, people from the investor world, physicians, people that were from health systems, health plans, people like me that have been in the policy world for a long time. And I think there are a number of barriers, but the thing that frustrated me was one being this short time horizon that investors have to look at, and those of us who work in Washington look at the 5-year budget window, and so it's really hard to invest in health and wellness. So even the most successful models that we were looking at were all at these highly complex patients that cost the system so much money, so that's where the money is, so everybody's going there. And even community-based organizations, people know they can deal with these highly complex, let's focus there, but we're not focused on preventing them from becoming highly complex in the first place, where I'm trying to think about how can we do that. And Efrem and I had a conversation before this about the diabetes prevention program, which I think is a really good example of Washington trying really hard to do something that's preventive. And it just came into effect, is mandatory for both Medicare Advantage and Medicare for everyone in April of this year. And it's something that in the Obama administration we felt very strongly about getting. I know people at HHS had to twist arms of people at OMB to get them to score it correctly so they could even get it in there. And what I heard from Efrem and also his colleague Tom Beauregard from United, that when they first put it out, people don't want to be labeled a diabetic. So they go in and they get the screening and they hear, you're pre-diabetic, and they say, great, I don't have to do anything, I don't have diabetes. And or when they got people to enroll, no one wanted to enroll in it. It sounds like a program that I don't want to do, and when they started to say, well, let's just call it a weight loss program, because what it was based on, and this goes back to a lot of things we talked about yesterday, it was based on a lot of evidence that people say, would lose 5% of their body weight, and if you do that, you really reduce your risk of diabetes. And having people go to the Y in their communities, doing things that are close to them and being part of this program. And so I think a lot of it too is how we're marketing things to get people engaged at it, where we could get other payers, because I think some of us were frustrated. Why do we keep going back to the healthcare system to pay for all of societal's problems? What are ways we can engage people to do this? So I just, challenge some of the investors in the group to think about, what are some ways we can really incentivize people to be focused on prevention and wellness, because I agree it's a very exciting time, but we're not quite there yet, where we're looking at ways that we can actually prevent them from getting to be complex patients in the first place.
Nora, I want to pick up on a point that on the time frame there, because I think it's absolutely critical, right? And it's the you need durable exposure, right, to a population and risk for it, right, for some of these payoffs to really make sense. And I think as such, there will be a variety. I mean, it's going to take a village to get this, but CMS, needs to lead the way, on many of these elements if we're going to get models that work and can really get at the trajectory of cost and of volume. I think, unfortunately, those in DC need to get their head out of the sand. I mean, when you look at, policies that have been coming of late, they're either misguided, misinformed, not bold enough, or in many cases undermining, any even basic progress that we've made to date. And, as such, I think we all have an obligation to start applying some threshold questions, right? That can start driving that policy, like, does it save cost, right? Does it move from fee-for-service to value-based payment, right? Does it at least maintain or increase quality? Does it align incentives? And if the answer is no to most of those things, chances are it's a pretty bad policy, right? But even that level of a litmus test isn't there, and until we get it, I don't think we're going to see CMS driving it, and we're not going to see sort of progress on models that have some type of payoff outside of 2 to 5 years.
Yeah, but I also want to build on that and just say why people aren't doing this. Because we in healthcare say health is the best out. Hemoglobin A1C, that's what's driving us. But if you're the person, the consumer, do we think hemoglobin A1C, we just want to live well every day? All right? And if you're already busy with a full-time job, in that 40 to 50 age range where this might be the most ideal, we know that for every chronic condition that you've got to change your lifestyle, you're talking adding another 5 to 10 hours of work in your daily life per week. Who's going to want to give that up? When we look at our, Medicare, the Medicare supplemental population, loneliness, low resiliency, pain, and low sense of purpose in life actually are more prevalent in that 65 plus population than diabetes, than obesity, all the things that we're pushing in healthcare. So we are too good at the should do's. We don't tell you how to, and more importantly, we haven't touched the heart to say, why should I?
Yep. Nice. Any other lessons learned from successful models of care, or even lessons, cautionary tales from the not so successful models?
Well, I would make one recommendation, for whatever business you're driving out there, and you heard it from Secretary Bonner earlier, this is not about age and being old and design for old. You don't design for old. You design for where is the fun in life, where is the vibrancy and the vitality of life, so that you draw people. People buy smartphones because they make life convenient, they make it fun, you are connected. We're not telling them per se to buy smartphones, but the market has created something that everybody wants. I think of Dove having changed the commercials to say, what, beauty is all shapes, all sizes, all ages. I love the fact that Allure magazine has actually banned the word anti-aging from their magazine, because it's not about anti-aging, it's about pro-life. And I think we should be talking, and Lou Sandy, one of my colleagues at United, is he said, you know, we shouldn't be talking about the ravages of age. What we really should be talking about are the merit badges and where that experience becomes an asset to the healthcare system and to us in the community.
Yeah, I think from a lesson learned perspective, we need to be careful not to introduce additional complexity, you know, into the equation. You know, the need for care coordination, you know, is there, right? But you know, the average individual, right, and the number of calls that they receive, right, you know, to help organize their care from individuals they don't even know, right, is increasing, you know, an unsustainable clip. And given sort of the trajectory of where prices at, the number of bill collectors, you know, calling them to pay for their latest $100,000 antibiotic, you know, it's probably an extreme example, but you know, probably not far off. You know, is also unsustainable. So we need to find ways to reduce the complexity rather introduce, you know, additional complications to the system.
Yeah. So do you think, based on that, the concept of, and it's not necessarily a health care per se, but really the idea of helping someone navigate through the entire journey of life as they are faced with boundaries or vulnerabilities. And I wonder if we've approached it so much of, I'm going to help you with this, and now we're recognizing it's not just this, it's all of that as well. And how would we create the opportunity to do that in a way that actually shows a return? And that's where we get into our own way sometimes, I think.
So I don't think there's going to be this Uber navigator that's out there that we're going to trust. I mean, just think about yourself. And I think that all of us, you know, now, and I'm not a physician, but I know many, and I know there are many in the room, complain about patients that come in, I Googled this, and I found this, and I'm taking all these vitamins and stuff. And it's like, oh no, they get all this information. So they're going to do it and maybe not tell you because you say you don't approve. But I think if you do things, as we said, the smartphone that people find interesting and engaging and then they want to do it, then people are, you know, if we're investing in those things that work for that person. So I'd go one step further than you, Charlotte, and say it's designing with people. Like, what is it if you're living with Parkinson's disease or diabetes or whatever it is that would make your life better? Right. What are the things that we can do there? And you do have to look at the margin. I mean, what we talked about were many that failed because in, for example, the home care industry, the margin is so small that many of these technology companies have gone out and expect people to pay a lot. And there's just all kinds of reasons why those startups are failing. But I think that, you know, I would say, I know we're getting the sign for the time, but you really want to be able to, you know, health plans, for all the good they do, they're not the most trusted person in the community. Yep. You know, so again, we go back to some of these issues of trust. Is it your physician? You know, baby boomers today often don't trust their physician very much. They trust their families and friends on those. So going to where people are getting their information sources, making it engaging and interactive so that you can see those returns in a way that doesn't make a bunch of false assumptions about what aging individuals and people with chronic diseases want.
Can I end on just a little positive note? Because, you know,
yeah, lift us up.
Just a little, you know, because, you know, we always say we're in the silo of healthcare and we're all talking about the financial security, and we all know having a sense of purpose, you know, volunteerism really helps with health. So I was really struck that Boston Medical Center, which is here in the Boston area, and they are, you know, the public health hospital. I was really struck, you know, when Kate Walsh, who's the CEO, said, you know, we have this program, and it all started because a resident was taking care of a mom and her family and said at the end of the visit, is there anything else I can do? And she slumped and she said, can someone just file my taxes? Now, you would just say, right, so the resident starts thinking about it and says, wait a minute, why can't we help this little workflow of life issue? You know, maybe they can do health if we do this. And so he contacted an AARP, and I'm not doing this because I'm at AARP, but I have to, you know, runs a volunteer tax aid program that helps people do their taxes every year. So they started inviting the volunteers in to help do taxes for not only their low-income patients, but their low-income employees. And in the first year, they returned $400,000 to these individuals. In the second year, $1 million. Okay? Talk about a whole person approach, thinking about the workflow of life, where healthcare reached across to finance, included the community and volunteerism, that's what's possible.
Right, and that's where I was going with navigation is we always think navigation's health. I was actually saying the exact opposite. To encompass financial, social, food, transportation, and allowing, and so then health becomes actually much broader.
I'm Doug Lehrman. This is our group over here. Nice. And I'm a financier, investor, advisor, et cetera. And we had two areas that we thought were very important. The first one, and I've never met Tim, but I know this will resonate with you. One of them is digital physical therapy. And, having spent a lot of time in the, as an investor and being involved in the orthopedic side of the space, bundled payments, et cetera, the need for digital PT for people to come home and get their physical therapy because they can't get to a physical clinic. They have no ability to. But not just that, they need to be able to be monitored. So if in 2 weeks after you've gotten a new knee, you're supposed to be at 35% rotation and you're not, there's a way to be able to connect directly to your orthopod's office, and then the orthopod can intervene through what they're doing, that you're either not doing it properly or not doing it at all, or something's wrong. And so the time to correct it is when you're at 20 versus 35, not when you're all done and nothing works. So that was one. And then just briefly, the second one, which is a little bit harder to pinpoint, but I think is really where a lot of chronic disease, and you see this more in the corporate world, and I'm not quite sure how it applies to the aging world, is the term mental resiliency. And stress, anxiety, how, as you're getting older, how you deal with issues, how your family deals with issues. And the whole point of that, if you look at many different chronic diseases, where it all starts is mental resiliency, and then the issues that come from that.
Great, thank you. Time for maybe one more? Maybe one here. Yeah, how about here? And anyone in the bleacher seats have one? Maybe we'll go way back just for kicks. All right, coming back your way next.
Okay, Teresa Lee with VNA Health Group. So this is our group right here, and we talked about really focusing on upstream prevention and wellness, but in sort of the context of what Charlotte had discussed, sort of whole person-centered care, really capturing what the patient as a person needs and wants, beyond just healthcare, looking at social determinants. And then Parker had a really interesting thought that, really what we need is to better understand the inflection points where seniors need up services. So sort of similar to the way banks think about servicing consumers. They might think of the first mortgage, the first first child, these first inflection points, and then making sure that we provide the right kind of navigation type services in that whole person way when the person needs it. We don't really need constant concierge service, and that's not feasible, nor is it, it's too costly and not necessary. But if we could just capture what are those inflection points and provide it when we need it and sort of withdraw afterwards, that might be a more feasible way to think about addressing aging.
Nice, thank you. Maybe way in the back for the last one. Yeah.
Okay. Hi, my name's Troy Mills. I'm with Carallel, and Carallel is it's a EAP program that supports the non-professional caregivers as well as a concierge platform. This is our group here, and we had a little bit different take in that, there's a number of programs. We spend so much time talking about healthcare, and one of the interesting components is there's a lot of things that are, we focus on these, the morbidity type of diseases, but there are things such as whether it's bladder control, whether it's sleep. There's a number of different issues that our seniors are still continuing to face, but how do we get better investment so that we can, take some of the social stigma out of that? We can come up with better solutions for them so that their quality of life as they continue to age gets better.
Nice.
I think there's some more opportunity in there.
Great, thank you. Panelists, any Final thoughts?
Oh, can I just want to build, because first of all the ideas are great, but I really want to build on that one on resiliency. Because to me, I think that personal determinant of health is how well you can adapt when life hits you and knocks you over and what gets you back up. We in healthcare have been so focused on the failure to thrive and not focused on the thriving. So when we're actually studying resiliency right now in that older age group and studying for interventions. But I can tell you, if you have a strong sense of purpose, you have fewer heart attacks, fewer strokes, fewer cases of dementia, 200 to 300 times percent the preventive services, 61% fewer nights in hospital, 32% fewer doctor visits, and in our Medigap population, a 40% lower per member per month healthcare costs, simply by having meaning in your life and a purpose. If you look at optimism and a positive view of aging, you have you live 7.5 years longer, 80% reduction in your cardiovascular risk, half the hospitalizations. And when you look at loneliness, hugely prevalent, the risk factor of half a pack of cigarettes a day, greater morbidity and mortality than obesity. And AARP just had published a study that Medicare pays $6.7 billion more per year on people who are isolated versus those who aren't. So the resiliency is not just in the workforce, I mean, it's throughout life, but we are now looking to say, if you're 65, if you're 80, if you're 100, can we still give you the tools, the personal tools, to adapt? And we believe that it will reduce utilization, healthcare costs, and better outcomes.
So I would just say, at the panelists, we all sat here and talked to them too, and one of the themes that we came up with is just make it simpler. You know, all of us were saying as people who work in the healthcare field, some with MDs, we get our annual statement from our health plan or something. None of us even open the envelope because it's so complicated. And we spend so much time counseling people to become eligible for Medicare. It's so confusing. And these are people that are well-educated, affluent people who can't figure out what to do. And so we were saying, rather than have this navigator that's gonna help us figure out everything about our life, have all you geniuses in the room do that in the back, and then we can have the Amazon of healthcare, where we have, you know, stars that tell us through validated measures what's the best plan to choose, what's the best house community to live in, what are these things, so that it makes our lives simpler to stay healthy and live well. I think everybody would be for that, but when it gets too many people coming at us, then we think, not more.
Nice. Good.
Just leave in, you know, the best success, though, is those of you in the AI and tech solve and move all that into the back office. And then the really successful ones that will soar to the top are the ones that add the EQ to the AI.
Just a point on urgency. I reflect on the charts that we see, you know, this meeting and others, and you think about the demographics, the trajectory of spend, the availability of family caregivers, and often the discussion is, you know, when do we really have a problem? Well, folks, we have a problem. I mean, like, it's not a, you know, it's not at some point in the future. There's a problem right now, and, you know, I think, you know, certainly there's an element of policy that you know, that needs to be advanced so that incentives are aligned. But I think there's an opportunity right now to think about innovating around how we deliver care, to be more coordinated, and we talk about sort of the navigation beyond just the medical side of things, but also to align expectations at every level, to align it at, you know, the provider, you know, inclusive of all providers, that we have to think beyond the house of medicine and think about how we all work together on the social determinants and others, but also on the expectations of, you know, the person and, you know, their family around them and their loved ones on, you know, what is high value and what is low value spend. And I think if we do that, we end up with a system that has smarter spend, we end up with a system that has better outcomes, higher quality, and ultimately lower cost. But the problem is now. It's not 5 years from now or 10 years, it will be worse then. But there's a problem right now.
Let's thank our preposterously talented panel. Thank you.